Anatomy of chest. The thoracic or chest wall consists of a skeletal framework, fascia, muscles, and neurovasculature, all connected together to form a strong and protective yet flexible cage. The thorax has two major openings, the superior thoracic aperture found superiorly and the inferior thoracic aperture located inferiorly. The superior thoracic aperture opens towards the neck. It is bounded by the bones of the upper thorax, manubrium of sternum, the first pair of ribs, and the body of the vertebra T1. The inferior thoracic aperture is almost completely covered by the diaphragm, separating it from the abdominal cavity. Moving forward with the skeletal scaffold of thorax, we have the thoracic skeleton. It is made up of the sternum, 12 pairs of ribs, 12 thoracic vertebrae, and interconnecting joints. Running between every two adjacent ribs are anatomical spaces called intercostal spaces. There are 11 in total. Circumference of the chest. The above line depicted in the picture should be taken care of by the physician while performing the physical examination of its patient. The lines are as follows. First is the anterior axillary line, second is the mid-clav axillary line, third is the posterior axillary line. The next picture shows the mid-sternal line, the mid-clavicular line, and the anterior axillary line. Lastly, the third picture here depicts the left and right scapular lines, and in between is the mid-spinal line. Anatomy of the lung. The various lobes present in the lungs are shown in this picture. The right lung consists of the superior lobe, middle lobe, and the inferior lobe. The superior and the middle lobes are separated by the horizontal fissure, whereas the middle lobe and the inferior lobe are separated by the oblique fissure. Moving on to the left lung, we have only two lobes, which are the superior lobe and the inferior lobe, which are divided by the oblique fissure. The picture here depicts the tracheobronchial tree, which is consisting the trachea, the right and left main bronchus, and the associated alveoli. The bronchuses are found in the associated lungs, which are the right and left lungs.
Hello.
Hi.
What's your name?
Bipasha Bhattacharjee,
Age?
51.
Okay. What do you do? What's your work?
And I am doing service in factory.
Okay. So today we'll be doing a lung examination. So first of all, I would need your permission to do that. Would it be fine?
Yes, fine.
Okay. Okay. Thank you.
Inspection. I would begin by observing the rate, rhythm, depth, and effort of breathing. Then would also listen to the sound of the breathing. Normally, adults breathe easily, quietly, regularly, about 14 to 20 times a minute. Then, I would inspect the patient's neck for supraclavicular retractions and also for the contractions of sternomastoid muscles. Normally, they are not present. Then next, I would check for the position of the trachea. It should be in the midline. After that, I would check for the color of the patient's lips and fingernails for abnormal color. Both should be pink for a normal patient. Then I would note the lateral diameter of the chest and also the anterior posterior diameter of the chest. I would check if both the ratios are equal or does one diameter look larger than the other. Next, I would check the posterior thorax. I would begin by inspecting its shape, symmetry, and deformities. Also would check the overlying skin of it. Then would start palpating the chest to locate any areas of pain or tenderness or to assess any lesions or abnormalities. Now, to assess respiratory expansion. I would place my thumbs on the patient's spine at the level of the 10th rib and spread my hands lightly on the thorax. Then would ask the patient to inhale deeply and exhale fully. while I'll watch for the divergence of my thumbs and feel for range and symmetry of movement.
Could you please say 99 when I put my hands on your chest?
Okay.
Okay.
99, 99, 99, 99.
Thank you. Could you please put your hands like this?
Okay.
And with you, we put some markings on your back.
Yes.
Okay. Now, when I put my hand on, you will just expire the whole air and just hold it for me there. Okay?
Okay.
Okay. Start doing it. Start.
Oh.
Now, you just have to inspire full air and then stop right there. Hold it.
Okay. Okay.
Stop. Repeat the same procedure on the other side. Again, expire air and hold it. Now inspire air and then hold it. Thank you.
Normal breath sounds. While checking for the normal breath sounds in a physical examination, I should keep in mind its intensity, its pitch, and its duration. Vesicular sounds. Vesicular sounds are soft and low pitched. They are normally heard during inspiration and the normal third of expiration, and is heard throughout most of the lung fields. Bronchial sounds. Bronchial sounds are louder and higher in pitch than the vesicular sounds. The expiratory sounds lasts longer than the inspiratory ones, and a silent gap separates these two sounds. These bronchial sounds are heard over the manubrium. Bronchovesicular sounds. Bronchovesicular sounds have an intermediate pitch and intensity. Inspiratory and expiratory sounds are equal in duration, and a silent gap may or may not be present to separate them. adventitious sounds, or also called as the added breath sounds. First, discontinuous sounds, example, crackles. Second, continuous sounds, example, wheezes and ronchi.
Again like this.
Yes.
When I auscultate, breathe one whole breath, okay?
Oh.
Breathe in. Could you repeat 99 when I put the stethoscope on?
Yes.
Start.
99, 99, 99, 99, 99, 99.
Okay. Now,
E.
just repeat E, okay?
Yeah. E, 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 E.
Now, you have to just whisper 1, 2, 3.
Okay.
Okay. Thank you.
Anterior thorax examination. To begin with the anterior thorax examination, I would ask my patient to lie supine and breathe normally. Then would observe the chest for any deformities, asymmetry, and respiratory movements. Then would begin the palpating the chest and would look for any areas of pain or tenderness, or would also assess for any lesions or abnormalities. Now, to assess respiratory expansion, I would place my thumbs on each costal margin and put my fingers over the lateral rib cage. Then would ask the patient to take deep breath and would watch my hands for divergence and feel for the range and symmetry of the movements.
When I place my hand, just repeat 99.
Okay. 99, 99, 99.
Thank you.
Auscultation of anterior thorax. While doing this, I would listen to the duration, pitch, and intensity of the expiratory and inspiratory sounds.
To breathe heavily, I'll auscultate. stethoscope, just repeat 99.
Okay.
Okay.
99, 99, 99, 99.
My findings for today's examination are: the thorax was found to be symmetric with a good expansion. The lungs, after percussion, were found to be resonant. The breath sounds were vesicular with no signs of rhonchi, wheezes, or any kind of abnormal sounds or adventitious sounds. The diaphragm, which descended, was found to be up till 4 cm on scale. There were no signs of bronchophony or egophony or whispered pectoral key. The findings or markings, everything for today's patient were normal. Thank you.